Sounds good.
And we can get started.
Awesome. Hi, everybody. Thank you for tuning in to the Northern New England CTR seminar series. So today's topic is Science in Service, a journey of mentorship, collaboration, and partnership. So just a few housekeeping items before we get started. Please mute your microphones if you're not a speaker and remain muted until the Q&A session after the talk. And if you have questions that come up during the presentation, feel free to type those into the chat. And after the talk, we'll use the raise hand function to ask questions. So with that, I'll go ahead and introduce our four speakers, all of whom are members of a research team investigating addiction medicine at the Maine Health Institute for Research, and their work was supported by the NNE-CTR in several ways. So first, Dr. Keena Thakrar is an infectious disease, addiction medicine, and internal medicine physician at Maine Health Center for Outcomes Research and Evaluation, where she studies the intersection of substance use disorders and infectious diseases. And then Dr. Michael Kohut is a cultural anthropologist specializing in qualitative and mixed methods research on how patients and clinicians navigate medical recommendations. Dr. Gloria Sklar is an implementation scientist whose work focuses on developing and evaluating community-engaged health interventions to reduce disparities among vulnerable populations. And finally, Deborah Burris is the lead clinical research nurse coordinator in the Maine Health Clinical Trials Office, overseeing investigator-initiated and industry-sponsored studies and supporting the research staff across the institution. With that, I'll hand it over to our speakers and can't wait to hear your talk.
Awesome. Thank you, Erin. And thank you so much for being here and for the invitation to speak today. It was really nice to be able to share what we've been up to for the past couple years. So with that, here are the objectives for today. So we'll be describing how the pilot funding really from CTR helped our team complete several research projects and really gave us a great foundation for applying for external funding. We'll talk a little bit about the outcomes that were supported by CTR resources and also discuss how, mentorship and collaboration really helped us complete our projects and help us put us in a good position for grant applications. So I'm going to attempt to advance my slides. Okay. So I wanted to spend a little more time, I should say, talking about the pilot project since it was funded by CTR, and this is going back a couple of years. So our pilot study was titled Rural Hearts, and at the time of the grant submission, Maine actually had the ninth highest rates of acute hepatitis B and C, which we thought were largely related to unsafe injection use practices. We had about we it was estimated that about 10% of cases of HIV were related to injection drug use. And at the time, we also had the ninth highest rate of drug overdose deaths in the nation. So we set out with the CTR pilot program to really characterize the knowledge, attitudes, and practices around safer use techniques. And the goal is really to identify factors that would predict uptake of services that are offered by community programs, such as safer use equipment, linkage to care, et cetera. So those are the main two aims of our pilot program. And here is the study design. So we recruited patients from four different hospitals in Maine. So this was really great. Deb, who will be chiming in soon, and I had several road trips around the state, so that was fun. We got to visit all of our sites. And we, over a 15-month period, we enrolled a convenient sample of 101 patients who were hospitalized with substance use associated infections and conducted surveys and also did chart review using the electronic health record. And so what we really wanted to do again was provide new information about how folks who use drugs were using community partner services and also identify barriers to accessing services. And, we hypothesized that really distance from community partner services would be an important predictor, sorry, that's a typo, of community partner utilization. So especially in a rural state like Maine, looking at these types of social determinants and barriers we thought would be important. So you can see the different outcomes that we were looking at there. Again, the primary outcome really being utilization of community partner services, which included syringe service, et cetera. And then uptake of new syringes, needles and syringes in the past 30 days. We also looked at secondary outcomes, which included other safer use equipment that people need to use drugs safely, naloxone, and also uptake of medications for opioid use disorder. So what we found was that, not surprisingly, only a third of the participants that we surveyed were able to use our community partner services regularly. Of those who did use community partner services, sorry, I should say that uptake of treatment, naloxone, and safer use equipment was not surprisingly higher in those who were able to access community partner services. And this is one of the publications we had, if anyone wanted to check it out. And here we highlight in our multivariable analysis on the right that folks who use drugs, again, not surprisingly, were much more likely to use community partner services if they lived within 10 miles of a community service program. And this was controlling for different factors as listed there. We had done logistic regression analysis, controlling for several of these confounders. The other sort of important data I think that really came out of this pilot program were also about, related to safer use. Not surprisingly, almost 50% of participants had naloxone used on them or had to use naloxone on someone else in the setting of a drug overdose. So, indicating that we really need to do a good job of overdose prevention counseling in hospitalized patients who use drugs. Of those who reported having used naloxone, most of them had gotten it from a community partner. The other thing which I thought was also quite concerning and frankly not surprising just given there's so much stigma around drug use is that most of our patients reported injecting alone in the 30 days prior to hospitalization. And this of course puts someone at very high risk of overdose if they're not using in the presence of other people. And then the other sort of interesting factor, sorry, the formatting's a little bit off there, but the other interesting factor was that many reported that they found that having mobile community partner units that could go out to their counties and supply these services would be very helpful. So we learned a lot from this study. I learned a lot from this study. So one was really just like how to write a grant. And then also grant management, which Deb, I'm going to give the floor to you in a second, but I'll just say that I learned so much from Deb. I didn't even know what like a regulatory binder was or any of these things. So Deb taught me a lot and continues to teach me a lot. In fact, I just emailed her a question last week. So shout out to Deb. I also learned a lot from Deb about recruitment strategies. It takes a lot of trust, I think, especially for vulnerable populations like folks who use drugs to want to engage in a study like this. And Deb, I think, had some really good concrete advice in working with the floor teams, et cetera, in terms of timing of like when to approach patients, et cetera. And for me, I just gained, experience, working with a multidisciplinary team. So Deb, I don't know if you want to talk a little bit about our time together on Rural Heart too.
Well, thank you for including me in this whole project. It was great. I learned a lot myself. I think one of the things that made it successful is to have all of the arms that reach out into research. There's really no one-stop shopping. So it was really good to be able to have somebody in different areas, whether it be somebody who does your data, somebody to do your day-to-day functioning of a trial. So I think that those are the pieces that make some of these grants really possible. We do find a lot of well, at times we find some, investigators who kind of want to do the whole thing, but we have some great resources here at the clinical trials office. Um, that you can access. And, it helps to have people that are in the clinical area at times because you do have a better understanding of, when are the best times to try to approach these patients. What are the things that they typically respond to? And another important piece of that is being able to develop relationships so that they will continue if there's follow up to return, because it's an awful lot of work when we've lost them. So I think that and just kind of networking with each other, because we did have multiple sites in this situation, getting tips from each other. I think that is just a really important piece of grants and making them successful from a clinical trial resource perspective.
Awesome. Thank you, Deb.
Mhm.
Um, Yeah, and I will say as I mentioned, we were able to publish these results, and I feel they're still relevant. For those that don't know, we have an HIV outbreak in our state right now related to um, folks who use drugs, and I just last week shared data from this project with the CDC to kind of inform some modeling studies that we're going to do. So like it's really come in handy in sharing it. In situations like that. We've used it for advocacy purposes, really um, sharing with state folks, highlighting the need to get mobile community partner services throughout the state, and we now have funding for those, which is great. Um, the other thing from the pilot program was that I think it just really made me reflect on like, well, okay, we know that there's a lot of folks who are hospitalized. Um, we notice that they're having very poor outcomes though. And so they're having really long length of stays. Many may leave the hospital early, which puts them at risk for drug overdose, for death, et cetera. And so having having done this pilot study really kind of made me think about, okay, like what are the next steps? What can we do to improve care? So with that, we also, this was very early on in the pandemic, applied for some uh, additional funding to look at accessing overdose and infection prevention services during the pandemic. So um, just some background before I turn it over to Mike is I think as we had mentioned from the prior study, we knew that accessing community partner services or certain service program services were quite challenging at baseline. And we were hearing from community partners very early on during the pandemic, there's issues and challenges that folks are having in accessing care, like certain programs are shut down or because of like the, safe distance rule, people were trying to figure out how do we get the supplies that we need. Um, so Mike, I can turn it out over to you if you'd like to go into more details.
Oh yeah, sure, thanks. Um, well, yeah, this was a really interesting project. I remember that it was happening pretty early in the pandemic. We were interested in kind of answering these kinds of questions. And so as part of the process, we basically reached out to different kinds of sources of information, which would include people who are using these services and thus have the most direct kind of view of everything, but also those providing the services who also have not only the view of day-to-day everything, but also have kind of a more of a bird's eye view overall of the kinds of issues that people were having. So we interviewed people who inject drugs, some of the community partners and healthcare providers in Maine. And that interview was really flexible. And kind of tailored to those different groups in order to really understand what kinds of issues were coming up on the ground. We identified a number of different things, some of which were probably not very surprising, but some were a little bit more surprising. So if you can imagine like peer support, who I remember one person who like worked in jails to talk to people and kind of they would talk about how if you're not there to kind of be there when someone's ready to take the leap to maybe reach out for treatment or something, you can miss those opportunities. And that was something that was really striking to me, was how important it was for people to be like there with people, and they're kind of providing that hand-to-hand interaction, and how obviously difficult that was during COVID, where that was obviously very discouraged. So a lot of really interesting barriers that people were running into. But we use the
Oh, sorry.
no, no, that's fine.
Sorry.
We were just trying to understand kind of different dimensions of this access. So in doing that, we use Pinchansky's model of access, which actually from this project and learning about the different models of access, I've gone on in many other projects to apply this same model. It's actually been really, really helpful and influential for me over time. But yeah, you can go ahead and advance it. I don't know if yeah, and so I guess I already kind of covered some of this stuff, but we did one of the things that we noted, and I think went on to publish about, was kind of the issue of eliminating the needle exchange in Portland, and how that sort of had some unintended consequences in different directions, for people on the ground who were trying to get that safe use equipment. Yeah, I could probably go on, but I know there's a lot.
No, thank you, Mike. I appreciate that. And I'll just say I learned a lot from Mike too about qualitative analysis, but especially in working with folks who use drugs, and kind of best practices and strategies for recruitment. So thank you, Mike. And Mike's been very patient with our learners too, and has done some fantastic work. So as Mike said, we use these data to really to we shared it, I would say with the state officials, et cetera, and have referenced it several times actually recently, when we've come across different drug policies that have come up in the state, around syringe service and things like that. So happy to talk with others in more detail if that's helpful. But again, the results from this study, I'll just reiterate, were really helpful from a public health standpoint and from an advocacy standpoint as well, in showing folks what worked and what didn't work during the pandemic. So. And then with more CTR funding, thank you, CTR. Got some time as a clinician scholar for a year, and I'm not going to go into great detail, but just wanted to say this as a clinician scientist. I was really grateful to get this time because I used it really to write more about drug policy issues, and also work with CTR navigators and trainees on some projects. So the first that's highlighted there is a drug policy paper, and the second was with Jenny Carwile, who was a research navigator at the time, looking at rural urban differences in hospitalizations for opioid-related infective endocarditis. So it was an epi study, which we published a couple years ago. And during that time, was able to apply for additional funding through Tufts CTSI, and also this Tufts CTSI work also laid the foundation for my current project, which is funded through the Department of Medicine here at Maine Health. So I just wanted to spend just briefly a little bit of time talking about this study, which was again inspired from all of these like sort of poor outcomes we were seeing in hospitalized folks who use drugs. And so many folks, as I had mentioned, would leave the hospital early. Many of them felt like they weren't getting a choice in their treatment decisions. They were just being told, okay, you had this really bad infection. You have to stay here for 6 weeks in the hospital with IV antibiotics, and take it or leave it. But what we did with the Tufts CTSI funding was develop a conversation guide, and Mike and others were really helpful in this process as well. And it was structured similar to the serious illness conversation guide, for those who are familiar with that in the palliative care world. So we worked with palliative care colleagues, hospitalists, and many other care team members in developing a conversation guide that was specific to choosing antibiotics for hospitalized folks who use drugs. So we developed this conversation guide. We piloted it at Maine Health with patients and ID docs, and we published those results. And we then went on with this DOM funding I have now through Maine Health. We're now rolling this out at 7 sites across the United States. In fact, I have a follow-up meeting with folks in an hour where we're going to review the results. But if anyone is interested in doing a deeper dive, I have the QR code there with the conversation guide itself. But I just wanted to highlight that in our pilot study here, patients really felt like they were involved in treatment decisions, which they really appreciated. And the healthcare professionals that we interviewed and piloted, they actually felt like it really gave them a better understanding of what patients were going through and patient preferences. And if anyone's into podcasts, we did a podcast episode on this. It's a podcast called Febrile. So with the current sort of academic pathway funding through the Department of Medicine, as I mentioned, we're now rolling this out at 7 different sites where we really refined our conversation guide, and we're training healthcare professionals to use it and getting healthcare professional perspectives on feasibility and acceptability of the guide. So this is where we are. This is like these numbers. Oh, I just realized I have to update some of these. Sorry. As I said, we just got the results earlier today. But we have 144 folks who have undergone the training for this conversation guide. Most are either in infectious disease or internal medicine. And essentially, there's a lot of data to go through, but basically I'll just say that almost all participants felt like this conversation guide was really helpful in a couple of ways. One, just increased comfort in understanding safer use, and also increased understanding and incorporating patient preferences into treatment decisions. And they all felt like the conversation guide really helped them provide that structure. So that's ongoing work. And then next, I just wanted to talk a little bit of some external funding, which again, I think was all based on this CTR work that we had done, which was, how do we make infectious disease and overdose prevention care accessible to folks who use drugs in Maine? And so we were really fortunate that we applied for external funding through SAMHSA and got a 3-year grant from them, and also got some funding from the Maine Office of Behavioral Health through their OD2A funding for Project Dharma. So I'll talk a little bit about Project Dharma, which is essentially, it was a collaborative approach between our health system and community programs in the state of Maine who are delivering infection and overdose prevention services to folks who use drugs. And I'll just point out that the logo on the left was actually a community partner participant who made our logo. So we're very proud of that. And that's some of our team pictured here in the slide. So we had several goals through Project Dharma when it first began. One was really just increasing the capacity of community organizations to deliver overdose prevention care and also increase their staffing capacity. We also started to do more infectious disease screening. So our community partner sites went through all the trainings and waiver applications to be able to do point of care testing. And I was really proud of the fact that we also brought novel fingerstick testing for hepatitis C RNA, which is ongoing now. This is the whole point, to make something that's sustainable, which really helped rapidly link people to care for hepatitis C if they needed it. And the other thing I'll just say is we started one of the biggest initiatives was drug checking. So I'll just preface this by saying I did not know a lot about what drug checking was. Jesse Gilbert, whose name is listed here, was one of the community partners that I spoke to regularly, and who told me as we were writing the grant, Kina, like you really need to include drug checking in this. And I was like, well, what's drug checking? What is this about? And it's for those who may not know, it's essentially testing the drug supply for contaminants. So contaminants such as xylazine, et cetera, which can be very sedating, can cause really bad wounds, et cetera. And so Jesse was really the one that said, okay, please include drug checking in this grant. I was like, okay, sure, we'll write something about drug checking. And something that I'm really proud of is through this work over the 3 years, we managed to pass legislation to make drug checking legal in Maine. And also we were able to use the OD2A funding to purchase the equipment that we needed and really like lay the foundation for drug checking work in Maine. And I'm not going to go through all these numbers, but I just wanted to highlight the work of the community partners through Project Dharma. I mean, they did thousands of outreach encounters, distributed thousands of naloxone kits, wound care kits, overdose training sessions, et cetera. So I think it was just really remarkable work that they had done. And then again, as I mentioned, for anyone who's not familiar with drug checking, we purchased 4 machines with that OD2A funding, which are called FTIR. So it's essentially using spectroscopy to test the supply for contaminants. And so this is essentially a step up from just using test strips where people can just use test strips to say, okay, is there xylazine or not? This is a bit more sensitive and specific, and people can get results in about 30 to 40 minutes. So we bought 4 machines, which are mobile actually, and can be taken from one site to another. And through this work, we arranged for complementary testing to be sent to outside labs for what is considered the gold standard of drug checking, which is essentially mass spec. And this is even more sensitive and specific. We also were able to get lots of training from our partners at Brandeis University and a lot of technical assistance from folks across the nation who are more experts in this than I am, but we've learned a lot over the past couple years. And with that, so our SAMHSA grant ended last year. It was set to end, thankfully. So, but we fortunately received funding from CDC and also the Maine Recovery Council to keep our project going. And actually now we're very much focused on drug checking. So I'll talk a little bit about the Maine Recovery Council funding, and then I'll hand it over to Gloria, who will tell us a little bit more about our CDC work now. But essentially through the Maine Recovery Council funding, we are really using this funding to fund our programmatic efforts through Project Dharma. So we're still distributing wound care kits. As I mentioned, we're still doing Hep C finger stick testing, for Hep C RNA testing, just distributing naloxone kits, et cetera. So really, we're using this as programmatic funding. And we now have a whole study team for our CDC grant. And Gloria, of course, is a co-I on the project. And we also have our community partners on the grants, who I did invite them to be here today, but they they said we can represent. But Anna and Ariel, who are executive directors respectively of Maine Access Points and Portland Public Health, Jean Bissett, Anna Moore, Kara Frankenfeld, and Erica Meyer are also part of our study team from Maine Health. And then Katie Hill is fantastic PhD student from Yale who has been helping us with our AIM-1. So let's see, Gloria, do you want me to take this slide or?
Either works for me.
Okay. All right, I'll give a brief overview.
Sounds good.
So in terms of the CDC grant that we have now, so if we are fortunate, we'll be funded for 5 years. This is a U01 study, implementation science study, with the goal of, as listed here, developing, implementing, and evaluating the effectiveness of a community-based drug checking program. And this will be a difference in difference to study where we're looking, comparing outcomes in Maine, counties in Maine that receive drug checking services versus counties in New Hampshire, which do not. And essentially, we're hypothesizing that improved access to community-based drug checking will improve knowledge of folks who use drugs and potentially lead to a change in behaviors and maybe a reduction in overdoses. I think there's a lot to be studied here and a lot to unpack. But and then here are 3 aims. I think I won't go in in great detail, but all I'll say is that we're sort of in the midst of aim 1 right now, where we're doing focus groups, and we'll soon be holding co-design workshops with an advisory board to really help us refine our implementation strategy. And then I'll let Gloria talk a little bit about aim 2 and 3 here.
Sure. Thanks, Kina. Yeah, so after AIM 1, where the drug checking navigator program gets fully developed with its implementation strategies, we then move into AIM 2, which is a trial to evaluate the effectiveness of that drug checking program and actually reducing, hopefully reducing overdoses. And so the design of this trial is, as Kina said, a difference in difference study design, where we're going to be comparing counties in Maine, which are in purple here, that have the drug checking program implemented by the community partners, comparing overdose rates in those counties to overdose rates in counties in New Hampshire that do not have a drug checking program. And so we'll be having a baseline measure of county level overdose and then tracking this over time over the 5 years of the grant once the program starts getting implemented to see how the program might impact overdose rates. So this diagram shows a potentially expected outcome of overdose rates in Maine, which are starting off at a baseline higher than New Hampshire, but that over time they would reduce. And so we can use that difference in difference trial design to show the true effect of the program, accounting for changes over time. And something we've been working hard on lately is figuring out the data sources for overdose data, which I have quickly learned is really complex. And I'm very grateful for the data analyst on our team and grateful for Kina, who's very good at establishing relationships with people really quickly. So we've been meeting with DHHS folks in New Hampshire and in Maine to understand vital records data, which gives us fatal overdose data, and then hospital discharge and EMS data, which gives us non-fatal overdose data. Non-fatal overdoses reported at an ED when someone's going to the hospital, and then non-fatal overdoses from an EMS response to someone and they're not being transported to the hospital. So capturing all the scenarios where an overdose can happen. And then the last data source we've started digging into is non-fatal overdoses just in the community. And that's from other syringe service providers in each state and talking to those guys about how they capture their overdose data just within the community when there is no EMS response or there is no going to the hospital. So we've been getting ourselves sorted around this trial data. And what's been really good about that is we're also forming relationships with folks in New Hampshire so that we can check that over this 5-year study period, there really is no drug checking program that's going to arise in New Hampshire, because if there is, we'd want to know about it to understand that we're actually comparing a Maine drug checking program to potentially a New Hampshire version. But in any case, we'll see if that happens, but that's a very good thing for us to keep tabs on. And so it's a benefit of forming relationships with these folks in these different states.
Awesome. Thank you, Gloria. And I forgot to mention, I mean, Gloria was also key in getting this grant, as sort of the real implementation scientist in our team. So thank you, Gloria, for that and your guidance. So before we close, I just wanted to say a couple words, on mentorship and also working with trainees. Very grateful to, there's a lot of folks I feel like I've learned from, including the folks on this panel, but also particularly just wanted to give a shout out to Doctors Kathleen Fairfield, Dan Diekema, and Rob Smith, who've really been great mentors to me since I came to Maine 10 years ago. So certainly could not have done this work without their expertise, but I also wanted to give a shout out to Wendy Craig, who couldn't be here today, but um, Wendy, again, is one of our research navigators and part of the CTR team, has just done such a wonderful job at helping me mentor trainees. And what Wendy wanted me to say today is that she's really enjoyed working with trainees over the past couple of years on all of these projects. And it's been really exciting for her to kind of see their trajectory in their career path. So again, just shout out to Wendy to working with us over the years on a lot of these projects. I think we've had about, at least just with Wendy alone, I think like at least 10 publications. And a majority of the publications, the trainee was a first author, which is something I think is just really cool. And it's been really great to keep in touch with many of them who have gone into like addiction medicine or ID, which is just really, really exciting. And these are just a couple of examples of some projects that were published, again, mostly around the ID substance use syndemic. And I still like just as an example, the, cost of treating infective endocarditis, this was done by a medical resident, Verity Ramirez, who's now a cardiologist, but, we share this cost data all the time with stakeholders, especially. So it's really impactful work. So I'm really grateful to the CTR for that opportunity. So yeah, just, in closing, I just wanted to say, this pilot funding really, I think, as we hopefully demonstrated, gave us access to a whole bunch of resources and helped us complete several research projects, publish, apply for external funding. I think, as we all know, like research doesn't happen in a silo, and collaboration, especially with our community partners and, learning from our patients has been really key to making this project work. And again, as I mentioned on the last slide, I think just another exciting part is just training the next generation who's interested in this kind of science. So I think I'll stop there. This is a picture of our Project Dharma team learning what mass spec is. We were visiting the chemistry lab at Colby College. So a lot of people to thank, especially all of our study participants, CTR, obviously, and the rest of our funders, and lots of people who we've worked with over the years. So we'll stop there.
All right. Thank you so much, Kina, Mike, Gloria, and Deborah. That was a really great presentation, very clear and on a very clearly impactful project. So thanks so much for sharing. And I just want to say this really embodies what we hope for the pilot projects, that they'll, be a jumping point to bigger funding and in publications and that sort of thing. So thank you so much for your effort and sharing that project with us. So if folks have questions, go ahead and put them in the chat or use the raise hand function. And I guess I can ask one to get us started. So I was really intrigued by the conversation guide. Can you elaborate on some of the considerations and processes that went into developing that guide?
Oh yeah, no, thanks for asking that. I realize I kind of breezed through that, but essentially it's so we based the framework for our conversation guide on the serious illness conversation guide, which is used very commonly, particularly in internal medicine, palliative care. So we use the same framework to really, ask the patient, okay, what are your goals? Do you understand the risks and the benefits of each treatment option? And, really making it clear that you come to a shared decision at the end. So it's essentially about shared decision making for folks who use drugs, instead of being like, okay, your only option is IV antibiotics. I think anecdotally, a lot of people were afraid, like, oh, well, if I offer them this oral antibiotic instead, like they're going to take that, which was actually not the case. I just realized I failed to mention this, but like when we first piloted the conversation guide, 100% of patients completed their antibiotics, and that's, their infection was treated, and that was their goal. So it's been really cool to see the conversation guide, again, adapted a little bit and now rolling out on all these different sites. So we're just essentially trying to make it best practice.
Yeah, Mike, go ahead.
I was just going to add to that we also did interviews with providers and addiction specialists and patients around the hospital in order to understand their concerns prior to designing the guide. And so those findings went into it as well.
Yeah, that's really cool. I can see how that is a very accessible, method that doesn't require too much upfront funding to have a big impact on improving patient care. So that's awesome. Gary, go ahead.
Oh, looks like you're muted. Sorry, Gary.
Now you can hear me. Okay. I think it's phenomenal, the program that you developed. I mean, and the benefits are obvious. The question that I had is there is there any capability to be able to adapt components of the program so it could be utilized on an outpatient basis or a hybrid model where you mentioned that one of the problems you encounter are people who go ahead and leave the hospital early. Is there any way that under certain conditions one can leave the hospital early with an understanding of follow-up?
Yeah, I know. I'm glad you asked that question. And that's actually something that we weaved into the guide, and tried to make it clear in the training. Like, the evidence shows that some antibiotics, generally speaking, um, are better than no antibiotics. Like, I mean, it's obviously common sense, but we now have studies to show that. But also, we weave into the guide, okay, if you choose oral antibiotics, can you follow up with someone? And we sort of tell people if someone's leaving the hospital early, that doesn't mean you can't do anything. Like, you can still offer vaccines, you can still arrange follow up. I tell them to contact me so we can see them at our homeless health clinic. Like, there's a lot of things that can be done. And so, yes, so I think part of, transitioning to outpatient care is sort of like weaved into the guide.
Thank you.
Laura, go ahead.
This was an incredible presentation, and you all are an inspiration to what we're doing in pediatrics, Kina and team. And I just had a question about sort of a population level with opioid overdoses declining in the last few years, both in Maine and I think New Hampshire. Is that complicating your difference in difference analyses? Or are you going to be able to show that the rate of change in Maine is faster than in New Hampshire, particularly thinking about the one of the many studies you presented where you're comparing counties in those two states? Or do you think that's a result of your all the work that you all have been doing at the state level for several years? Because it looked like in your sort of pilot, your pre-intervention phase was right around the time that the tide started to turn on opioid overdose fatalities.
Gloria, do you want to take this one first? Or thank you, Laura.
Sure. Yeah. Yeah. No, thanks for that question, Laura. So the difference in different study design actually accounts for that potential temporal change. So it's going to place that aside and then only show the effect from the intervention or what we could likely attribute to the intervention, accounting for anticipated temporal changes.
So that slide that showed the parallel trends pre-intervention, I think it was like slide 31, is sort of more of a conceptual idea because it showed sort of the overdoses increasing over time, but then a bending of the curve in Maine.
Yeah, that's not real.
Okay.
Yeah, that's not real data or anything. It
not to be taken literally. Okay.
Yes.
Helpful.
And actually, that was the amazing thing about that CDC grant is we originally submitted it a couple years ago now, and it wasn't funded, and then we resubmitted. So actually, our starting point is not 2023, but it'll be 2025. But in any case, no matter when we start, that trial design will account for temporal changes.
Mm-hmm. Thank you.
Any other questions? looks like not much is coming up. So I guess we can wrap up just a little bit early today, if that's all right with the organizers. So thank you again to our speakers. This was a really inspiring presentation. And thanks everybody for tuning in and giving your time and attention. And we'll see you at the next one. So have a good weekend.
Great. Thank you.
Thank you.